Good afternoon, everyone. Thank you for being here for our office hours on building resilient and sustainable sobering centers in California and beyond. My name is Meryl Schulman. My pronouns are she, her, and I'm a senior program officer at the Center for Healthcare Strategies, or CHCS, and I will be your facilitator for today's event. I want to start off by thanking the California Healthcare Foundation, or CHCF, for supporting this work. To thank you to my colleagues behind the scenes for their work in pulling together today's event, and to each of you for being here today. Just on a quick logistics note, and I saw my colleague Michael just put this in the chat, we are recording today's office hours, so you will receive that recording and the slides as well as the materials that we talk through today following today's event. Next slide, please. So briefly, before we dive into the meat of today's session, I just want to share a little bit about the Center for Healthcare Strategies, or CHCS, for those of you who may not be familiar with us. So CHCS is a nonprofit based in New Jersey that works with different stakeholder groups nationally to strengthen healthcare services to ensure better and more equitable outcomes, particularly for kids and adults served by Medicaid. Since 1995, we've worked in every state in the nation, and we do our work in partnership with state and federal agencies, health plans, healthcare providers, community-based organizations, and consumers to make healthcare work better for people who face serious barriers to well-being. Through our work, we work to advance more effective models for care delivery. We'll be talking about one of those models today, so brain care, obviously. We work to advance more efficient policy and program design. And across all of our work, we focus on more equitable care and opportunities to address the obstacles that stand in the way of health equity. So that's a little bit about CHCS. Next slide, please. So on this side, you can see our agenda of how these office hours are going to work. We invite you to settle in with us. We hope that this is an event where you feel comfortable coming off mute, asking your questions, engaging with us and your colleagues on this topic. But broadly, here we are at Welcome and Introductions. Soon I'll welcome our colleague and subject matter expert on sobering care, Shannon Smith Bernardin, who will be talking about best practices for sobering center implementation, as well as a couple of new tools that can support the adoption and implementation of sobering care. And then the bulk of our time, about 40 minutes or so, will really be spent on question and answer. So we will go through a number of pre-submitted questions that you all submitted during registration, and then we'll also take questions live from the audience, and then we'll wrap up. Next slide, please. Okay, so speaking of your participation, there are a few ways that you can submit questions for Shannon today. The first is you can submit your question in writing using the Q&A icon at the bottom of your screen. The second way is you can ask your question verbally. So to do so, please use the raise hand feature so I can see that you have a question. And then I will call on you and we will unmute you to ask your question of Shannon. If needed, you can also drop that question into the chat, but it'll be a lot easier if folks can just use that raise hand feature. And then if you joined by phone and are audio only, you can email your question to my colleague Amanda Bank to her email at abank, ABANK, at chcs.org. Next slide, please. Okay, so you already met me, but I'd like to introduce our next speaker, Shannon. Shannon, thank you so much for being here. Shannon is the co-founder and immediate past president of the Collaborative. She's also an associate professor at the Department of Social and Behavioral Sciences at UCSF, and she has a wealth of experiences implementing and supporting sobering programs in California and nationally. Shannon, thank you so much for being here. So with that, I will turn it over to you to share a few words about sobering care and also some of the resources that you've led the development of.
Okay, well, thank you, Meryl, very much, and great to see everybody here today. I'm excited to come and talk about sobering, and I think one of the main reasons and kind of the idea around doing this office hours is that there's every time we ever get in conversations around sobering, and from sobering 101s to all the variety of program descriptions and whatnot, all this type of stuff that we go through, is the Q&A at the end ends up being excessively long. There's always more questions. There's always so much nuance in sobering and how it goes into your own communities that we wanted to create something that there'll be more time. Like, I'm going to talk right now for 8 to 10 minutes, introducing a couple main resources that we have available, and just kind of getting your thoughts going around what questions you want to ask around services. So we can start the PowerPoint now. Let's jump right into it. On to the next slide. Excellent. Okay, so the quick of Sobering Center. What is a Sobering Center and why do we have it? And basically, this is a service for individuals who are intoxicated, who their current level of intoxication puts them at risk. They are unable to take care of themselves in that moment. And we want to have them go someplace safe that they can be monitored. Right now, if a community doesn't have a sobering center, those options are very limited. They're either left in place wherever they happen to be, which comes with risks potentially, going to the emergency department or going to jail. And this is an alternative for all those first responders and families and friends in one's community. And with the idea and goal that it's a safe environment, it's a short-term stay, anywhere between 6 to 12 hours, a little bit longer, depending on the substance of intoxication, where they're frequently monitored. They have supportive linkages that can be offered to them at the end of their stay that may be related to their substance use or some other social need that they have, signing up for insurance, getting into shelter, etc. And one of the main things we look at is trying to keep people into a care environment that is appropriate for the level of care that they actually need. And we can go into the next slide. Part of the overview of looking at why would your community want a sobering center. Now, if you already have one, what are ways that you can enhance it? And there's a variety of business cases that are made for sobering. Very basic straight off is keeping people out of more intense environments that don't really necessarily take care of the individual at the level that they need for intoxication. So they're going to the emergency department. They don't need a high level of care in that moment for the intoxication. They're going to jail, which comes with its own long-term potential repercussions for the individual and the system itself. So we're trying to reduce arrests, the courts, having people, all the benefits that can be lost and the impacts on someone's life from going to jail for one visit. Also, just for, even if we're looking bigger than the individual into the system, officers, when someone comes to the sobering center, law enforcement can come in, give a quick report, and be back out in the field for public safety within a few minutes. Versus many communities, the shortest I've heard is around 45 minutes, but more typically, at least an hour or two, up to 4 hours plus for those two officers to book someone into the jail system, plus all the other staff that entails. And when we have all the different ways that we can have better economics in terms of time savings for staff, for emergency medicine, emergency department staff, if there aren't any options and maybe they'd be left in the field, the risk of someone who is on a sidewalk who may be intoxicated, the risk is pretty high for someone being assaulted, for someone having a different medical need that may need assessment, and that can be avoided with this option of a sobering center. And then looking at the individuals, they get peer engagement. This maybe they may come to the sobering center one time and never come again. This is one bad night that they had, and they get to engage with staff members who have experience in substance use and other areas that may overlap with this individual to kind of have a conversation. How did you get here today? Do quick needs assessments. What else do they need? Referrals someplace, shower and a meal. Very short term, huge wins for the individual, with the idea that we're trying to also stabilize people and offer them things that may help them in the long term. So maybe case management on site, if it's someone that's repeatedly coming into your program that may have higher level needs, how do we wrap around them a little bit more to offer them everything from shelter to maybe they go to the emergency department lot also, emergency department case management that you can work together with, and then everything from treatment, integration to community services, and the comma, it's supposed to say more things after it, but there's so many different options out there. Next slide. Over the next like 3 or 4 slides, and then I'll be able to wrap up so we can go into Q&A, is I'm excited to talk about, and I know some of you have probably accessed this already, we have, that came out in the fall, 2 main resources from that was funded by the California Healthcare Foundation, which is a blueprint for sobering care in California implementation guide. And this was based on, I had worked on with a group of people a deep dive into sobering care in California back in 2021. And then last year, throughout the spring and summer and fall, we looked at, again, what was going on in California. And based on the knowledge both there and what's happening else in the rest of the country, put together a resource that literally walks you through from the moment of conceiving of sobering in your community all the way to full implementation. It's up and running and doing evaluations and assessments and figuring out sustainability of your program and how it fits into the services there. And I really want to emphasize this. This is a blueprint. The overview itself is something that is good for communities that you're just considering sobering. You've heard about it. It's a great, like if you're in California itself, it does have information in there regarding the CalAIM Medicaid reimbursement options for sobering care. And it also has everything from example protocols, example policies as people get into the program itself, from how to be identified in the field through their stay in the sobering center. And then we're going to basically kind of look at inside the blueprint itself. There's everything from staffing guides to glossary terms. If your work has been primarily in a different faction, public health, behavioral health in general, kind of where's the language around how sobering fits into the community. So let's go forward in a few of the slides here. I'll kind of outline some of the things that the blueprint covers and that you should consider in your own community when one is looking at here an assessment deep dive. So let's just say you have a program that offers some level of care for intoxication in the community, maybe a sobering center, maybe not, or you're trying to start one, or you've had a program that's been there for 15 years and you're trying to enhance the services. A lot has been learned about sobering care in the last decade. Prior to 2011 or so, there was one article out of Australia on sobering care. That was it 20 years ago. And then in the last 5 or 6 years, we've had a huge amount of information that's come out. So when you're looking at sobering your community, you kind of want to assess based on what's the newest knowledge around what are all the resources available? What do you have in your community as far as existing services, as existing sobering, existing jail, emergency department? What you don't have? Do you have access to homeless resources, street nursing, street medicine? Do you have access? Do you have a homeless shelter? Is there a detox? Is there a mental health facility that someone could go for mental health crises? These are all the things you want to look at in one's community or where sobering could fit in, and or if you have one already, where you could expand the service model to help figure out what would be the most helpful. And the blueprint also walks through a lot of this. Let me look at the slide real quick. For the feasibility study, I will just point out briefly here, and we can folks can ask questions about it if you want to also. I think one of the most important aspects of creating a sobering center is the idea of how big do you make it and what model of care do you have? And there's so much that goes into figuring out what the capacity should be and what the utilization would be in the program. That is not straightforward. If you have 2,000 individuals that are cared for a year for intoxication, you don't go to sobering and say, okay, we've got 2,000 a year, let's divide by 365. That's the number of the beds we should have in the sobering center. doesn't work that way, and we can dive into that a little bit more later. Okay, let's go to the next slide. Now I want to make sure I wrap up in time. All right, so who needs to be at the table for sobering care? And I'm glad to see a lot of you in the room. I recognize some friendly names and faces out there. Who, when you're looking at sobering care, the hospital system itself, emergency medicine, behavioral health providers, the law enforcement, sheriff's office, your local police department. It's a combination of city and county. It may be regional, depending. Many communities have using emergency medicine as an example. Some counties have an EMS county group. Others have a regional EMS authority that kind of oversees 4 to 8 counties in one giant group. When you're looking at individuals who have sobering care, I think one of the most important aspects is, what do they need? What are the resources that individuals will require to become more stable, related to substance use and related to everything else going on in their lives, from poverty, homelessness, job loss, etc. And with this idea that you're bringing everybody in the room, I can guarantee that almost every single person in the room is going to have a little bit different idea of what sobering is, why they would want to have it, and the benefit to their own department, to the individuals that they serve. And how do you kind of line up all of those goals, what that goal looks like in terms of fulfilling it, and how do you measure it? And then how do you know you've measured success? And looking at all of that together is kind of coming into this common ground of, what do we want for the individuals that we're serving? Where the money's coming from? And we have a couple questions that were sent in ahead of time that we'll talk a little bit about funding options. How do we reduce costs, both financial and time, as I mentioned earlier, with, say, law enforcement time, EMS time for drop-offs, while looking at this population to improve their outcomes, where sobering is just a piece. I will just say right off the bat, you're not going to start a sobering center and solve all the problems in the community when it comes to intoxication. And it can have a huge role, and it's pretty amazing to connect services. So let's jump forward to the next slide. So looking at financial planning, there's a lot that goes into it. Maybe your community has a building or a floor that already exists. You're like, this is where we want to put the sobering center. So some of the startup costs around facility build out may be more limited. Other times you're going to have to purchase buildings. Looking at licensing, there's a question on zoning that hopefully we'll get to today, and what you want to put in that facility. When we look at sobering across the United States, typically most have a budget of over $1 million. There's a handful that are below $1 million, anywhere between 450,000 to 900. Really depends on the community and the staffing. The staffing is the majority of the budget. And when you're looking at a sobering center, where can the monies come from and where's the benefit to the system? They will not always align, but one can do the best they can to figure out if this particular department is paying 50% of the sobering center. They may not see a lot of the benefit of it, but other agencies will. So how do you kind of work together in a person-centered way? And the last thing on this bullet point that we have a link for it in the chat is a financial planning tool. So along with the blueprint, which busts through all of best practices, funding sustainability, managed care contracting resources, et cetera, is an Excel custom spreadsheet that looks at all the potential costs that go into a sobering care program. And you can kind of punch in numbers like, okay, well, if we upgraded to a licensed vocational nurse and or a paramedic from an EMT during the day shift, how will that affect things? So it's a very specific tool that will help kind of navigate changes that you make to your program. If you want to add on a particular staff member, say we want to add on a case manager, how will that help you figure out where the benefits and the costs of that will be? Next slide, please. And then for looking at working in your community, is that at the beginning, there's a lot of it's just needs assessment. Do you need a sobering center or not? You may look at it in your community and say, yes, we have a challenge with public intoxication, and we have at the same time the individuals that we're caring for who would fit into a sobering center also have these 3 other needs that may be larger, medically fragile individuals that would benefit from respite, a lot of very spread out homelessness, where they are in like nooks and crannies essentially of a community where to get to those individuals on a regular basis, maybe a street medicine or a street health outreach team and or a regular outreach team who can collaborate with medical professionals to get out there. So how do you figure out the needs assessment of the population and bring those folks to the table? And then you figured out the funding we mentioned earlier. Site selection is probably one of the more challenging aspects. Every once in a while, we get a community, and I want to cheer. They're so lucky. They basically have a site already. It's gone through all the logistics. They're going to be able to make it happen. Other communities, it could literally be 3 to 5 years of navigating NIMBYism, the not in my backyard, or navigating zoning rules or new construction laws that, that maybe had the best intentions when it was created as a policy or something in your community like a proposition that now you're like, it's restricting us from just adding an extra bathroom or something. Figuring out that step could be quick. It could take years. So just kind of start being ready for that, I guess is the best way to say it. And then lastly, the middle of developing one, everything from preparing the building, figuring out what supplies are needed, getting core leadership in for the community-based organization, typically who's going to be running the program, getting them onboarded, policies, staff recruitment, training, getting all the folks from the community. Now you've got your coalition of emergency medicine providers, emergency department, the health department, the local recovery community, sober living, et cetera, leadership and admin, and those folks have been in the room. We want frontline at this point. We want to be working it, and ideally earlier, getting these folks ready to be able to bring people to the Sobering Center, receive calls from Sobering Center staff, et cetera. And then it is the one last thing I'll say on this section is things can change frequently. And so you can start with a soft launch. Restaurants start with a soft launch. You come up, test things out for a little bit. You have literally a limited menu of services of this particular referring party is who we're taking in for the first month, for the first 2 weeks. Work out the kinks. Can they get the back door open? Does everybody have a key that can open this particular area? Who needs a badge? Who doesn't need a badge? Pilot it. Soft opening, making sure, and then we can get on to that. All right, so let's, next slide. And I think this is my last one, if I'm correct. And then staffing models, we're going to dive into this a little bit more. There's all kinds of staffing models out there, which I know some of you have been working with. And it is everything from medical staffing to et cetera. But I think you'll get the slides. Keep going. Let's go for the next slide, please. Awesome. And then the last section here is basically on how to evaluate success. And it is from immediate to the bigger picture of where folks are being served in the community. And it is both outcomes of the individuals. And the second thing I'll stress here is it's outcomes of the system, but also the process. How well is your community able to collaborate together? Is everyone coming to the table who is providing services in your community? That is a way to evaluate the process. Next slide. All right, and so we are ready to open up to Q&A.
Thanks so much, Shannon. Okay, so just a quick recap. We have the questions that folks submitted in advance. If you have questions that you'd like to ask Shannon, you can submit your question via the Q&A icon. You can also drop it into the chat. We're not that large of a group, so I can manage that. You can also raise your virtual hand using the raise hand function, and then we'll ask your question. Or if you're audio only, you can email your question to my colleague Amanda at abank@chcs.org. Okay, but I'm going to start us off because we do have a number of questions that folks submitted. So the first question, Shannon, is from Nancy Bem out of an organization called Rooted Life in California. And Nancy indicated in the registration that they are considering starting a sobering care program. Their question is, and you mentioned this in your talking points very briefly, but what is the recommended staffing model for a sobering center based on the reimbursement rates providers are receiving? And again, she's in California. But what would you say to Nancy's question?
It's an excellent question because you want to make sure that you can afford to pay the staff that you're bringing in the door. Two different things I'll kind of start with. The first one being with the staffing model itself, we are recommending in general, and I wear the we hat a lot. We have the National Sobering Collaborative doing a shout out. I know our executive director, Shauna Goodman's in the room today. There are standards that have been put out. We recommend in general an individual healthcare provider. So some level of health, medical, nursing provider who can do assessments, and then a peer level staffing. And this could come as a peer professional, someone with lived expertise. Having those two at a minimum standard for sobering care. For the reimbursement rates providers are having, the EMT and peer level is the minimum standard, I would say, with the idea that the reimbursement model will not, a sobering center will not break even on sobering care as a reimbursement model. And mainly because there's a few considerations. One being, you want anyone who's intoxicated to be able to come into the sobering center and not be screened out. Sobering doesn't restrict based on someone's identification or someone's lack of or access to healthcare or health insurance. And so you don't want first responders out there saying, okay, I can't bring anyone to the sobering center unless they have these particular 4 insurances. So you're going to have folks in the door who are not being billed for. With that, though, even if your state doesn't offer sobering reimbursement, the ability to bill for other services is available potentially to you. Is your sobering center co-located with another program? I'll use medical respite as an example. The medical respite may have a licensing that goes with it, and they have nurse practitioner staffing. If that nurse practitioner could help serve the individuals in the sobering center, there may be a billable component to that. And then there's also a lot of different other options that are potentially covered with insurance. Enhanced case management, medication-assisted treatment, getting folks onto medications. There's so much excellent work going on with community health workers. So when you're looking at the community, are there ways that you can bring in some of those staffing to work with, for example, repeat individuals, clients who are coming in again and again, who may need more stabilizing care, patient navigators, et cetera, and that those services could be billed for. One of the things that is important to know is there isn't a licensing for sobering centers. We do have an accreditation program that CARF has created for this, that opens up this year, but there isn't a licensing for sobering centers. So that's not something that would work with the billing. Like there's lots of different billing things that happen with licensing. I know.
So Shannon, oh,
Mhm.
sorry. I was just going to say, I realized that Nancy is on the line. And Nancy, I'm
Oh,
sorry, I
excellent.
didn't see that you were on the line when I asked your question. Um, I'm going to allow you to unmute yourself in case you have any context or response for Shannon, and no worries if you have nothing to add. But we'll just give Nancy a moment in case she has any context or follow-up questions for you.
Hi, sorry for joining late. Nothing additional to add. That was really helpful. So thank you.
Thanks, Nancy. Thanks, Shannon.
You're
Okay, we
welcome.
have another question that was submitted in advance, and this is actually from another participant who is on the line, Candy Stewart out of Alaska Medicaid. Candy, welcome. So Candy, I'll ask your question, but I'm going to unmute you before Shannon responds in case you want to add any context. But the question that Candy submitted is, what can Medicaid coverage for sobering care look like? And Candy, you're going to see me unmute your line in just a moment.
And welcome, by the way. I live at there's 3 or 4 sobering centers in Alaska, I believe. I may be wrong. You probably have more information on that at this point.
Yes. And I think one of the things that we tussle with is Medicaid funding for sober centers because historically they're not covered under Medicaid, just the individualized services like you're talking about that could be billed out.
Mhm. Yes. So, and you guys are kind of exploring that potentially for Alaska is doing it more of a reimbursement model for sobering care. Is that what you're considering?
I think it's being kicked around, yeah.
Yes. We had so California is, as far as I know, is the first state to try to work with this. Maryland is also, and there's a couple other states that exactly like you said, are kind of kicking around the idea of what it would look like. What was really excellent in California is we've had some lessons learned. So with the reimbursement model at the moment, an individual comes in for sobering care. The communities that in California, the communities that have reimbursement models have basically created there's individual MOUs with the county, the local healthcare plan, or the managed care plan in that county, and either the exact provider, the operator of the sobering center, or typically the county who is helping fund it. So it doesn't have the CBO itself, the community-based organization who's running the sobering doesn't necessarily have to be the one who does the contract. They may have to provide data though. And some of the things that have come up that have been excellent is at the beginning, lots with insurance, pre-auths have to happen for someone to be able to bill for an engagement. Pre-auths don't necessarily work for sobering care because the individual is intoxicated, they're being brought in at the moment. So over the years, some of the things that they've now, we've changed, and I say we, I am not part of CalAIM and all the powers that be and the amazing people who've done it. So I take zero credit. I just use the word we a lot. No pre-auth is required for sobering and no post-auth. And so what used to happen is, okay, they're like, okay, well, they don't need pre-authorization, but someone come to sobering and they still have to do a post-authorization to get that approved and then be able to bill. Now you can just bill. Someone comes to sobering, they're cared for, you can bill if they have insurance. Not restricting individuals to a sobering center who only have that insurance. So now if you're working with 2 local healthcare plans, the sobering center can accept whoever is still referred that's appropriate with intoxication. They don't limit to just those. You just can't bill for the other individuals, which is how it's been historically. Minimal data requirements would be the second thing. No pre-auth, minimum data requirements, basic client demos, demographics, admit discharge times, and results of where they went. And basically just having very limited information that needs to be collected. No client signature. That was another thing that got kicked around a lot. Of a client would have to sign to say that they were accepting services, but they're also intoxicated, and we all know that. And so at this point, I don't know if anybody requires, when I say anybody, any county or like healthcare plan currently still requires client signature. I think that's been removed from all of the ones that were being piloted throughout the state. And then the 2 other thing is, how do you demonstrate that someone actually needs to come to the sobering center? And what validated screening tool is appropriate? The CWA, which is for alcohol withdrawal, is one that some programs, like the health insurance company was like, we want every client that comes in to get a CWA score done. Are they in withdrawal or not? Here's their level. That can work if you get a lot of alcohol. Doesn't really mean much to anybody else, but you also don't want them to be in withdrawal. There are some loose intoxication scales that have been created for emergency departments that may be able to work, and I can get that to you if you're interested. But basically not requiring, as part B of this, large screening tools to be done on individuals. Originally, there was questions on whether or not we wanted to have everyone get a lot of the mental health screenings, PHQ-9, are they depressed, all the anxiety scores, and get a substance use screening, and the client's intoxicated. Their stay is 5 hours, not requiring all of those high things were some of the lessons learned that have happened in California. I really look forward to see what other people are going to do in other states. And I think that was the main thing I was going to say on that. Is that helpful,
Thank you.
Candy? Is there more?
Yes, very helpful.
Thanks, Candy. Okay, so we have a couple of other questions. So this question is coming from, it doesn't look like this person is on the line, but I think it's a good question. And it's coming from someone who works at a health plan in Oregon State. And they're asking, how are sobering centers embedding trauma-informed practices into organizational culture and day-to-day operations? I'm wondering what you think about that, Shannon.
Yeah, this is it's an important question, and I love when I know that, my people are in the room. So I think sobering, one of the main things that we do is for trauma-informed care, there's some basic principles around it. I'd say the peer support aspect and the safety aspect for both the clients themselves and the staff in an environment that is welcoming and is allows the individual, appreciates the cultural areas that the individuals come from. So I'd say the main things, examples of trauma-informed care. meeting the person where they're at. De-escalation. This is in general, some sobering can do they'll take individuals on involuntary holds, but the vast majority of stays for people in sobering across the US is voluntary. They have the choice to go there or not. They can leave when they want to. If you think someone's super unsafe and they're going to be injured, then the staff are now working with them to help try to figure out that they're not going to be getting more injured when they leave. So that's kind of really staying focused on the individual, what their needs are. Treating people to people, minimal expectations to be there as long as they're behaviorally appropriate per se. We don't think that they have anything big or wrong with them in terms of a medical need or a psychiatric need. Would they be safe in the environment? Then they're welcome. They don't have to agree to anything. They don't have to agree to a shower. They don't have to agree to a meal. They don't have to agree to really anything at that point. And then I'd say two areas that we see, I'd say it's highly trauma-informed, is the denial service protocol. There's going to be times where someone comes in and their behavior is not amazing. And you're like, okay, we just don't want this person to come back for a little while. Very rarely is there a permanent denied service to an individual who's come to a sobering center. Maybe they had a bad night. Maybe they did get aggressive and they tried to hit somebody, but they don't receive a permanent denial. It might be temporary, and it'll be something where the sobering staff will literally try to have a conversation with this individual in the future, or talk to like their case manager and say, hey, let's all talk, and hopefully that won't happen again. The second thing is recidivism in terms of people being able to come back. They can keep coming back to the sobering center 52 visits and have never gone to detox because maybe they don't want to go to detox, but they don't have to go. They don't have to uphold any level of, what's the word I'm going for? They don't have to agree to someone else's care plan in order to keep receiving services at the sobering center. Their needs may be very different than what someone else might think would be super helpful to them, but they don't have to agree to it. And so that's, some basics on that part there.
Thanks, Shannon. So we have a different question. And then Nancy, I saw that you had a question in the chat. Then after this question, I'll turn it over to you to ask your question verbally. So there is, thank you for the thumbs up. That's super helpful. So there's a question from Sarah Richardson, who works at Gateway Foundation in Illinois. They are considering starting a sobering care program, and they have two questions. One of them is about zoning. So the first question is, what zoning considerations do we need to think about? And this is an interesting question, just building on like your comments about staffing. What does the overnight medical nursing staffing look like typically at a sobering center? But let's first start with that zoning question about zoning considerations, Shannon.
Yeah, that's a great one. With the zoning, the nice thing is, okay, so I'm not going to go down the weeds. I love to just chat too much. So sobering is not a residential facility, so it does not have to go into an area that is zoned for residential. It can fit into commercial or institutional zones as much as it could fit into a residential zone. Many sobering programs, in addition to the residential aspect, is the mental health programs that are available, where if someone stays 24 hours or more, then it does count as some type of residential, and there's additional licensing requirements. So most sobering centers will have a length of stay maximum 23 hours, 59 minutes. We can alt tab to that if someone wants to talk about it more later, but because it's non-residential, you don't have to fit into residential laws. You do want to have in an area that is accessible. So I'd say non-disruptive parking and transport for referring parties. So you could have a sobering center in the middle of a commercial zone, and there's nice ways to do windows. You have all kinds of programs everywhere. As long as, let's say, police and ambulances who may be coming in or out, can they access from the back? Because if there's a bakery next to where you're at, you don't necessarily want individuals coming in and out the front door and a police car parked in front of the bakery all day. Because the bakery's like, we don't want people parked in front of our building with the law enforcement all day long. So how do we get them a better access? That would be the main thing I'd say with zoning. And then with the NIMBYism, it's less a zoning situation and more of where's a good area that a community would be okay with someone with a sobering center. It's not a shelter. And so there aren't people waiting in line outside, which is often a concern, but we do want to make sure that it's non-disruptive. And when people leave, are they close to resources and they close to public transport or some way that we can get them driving them someplace else, such as a van. So hopefully that's a little bit helpful. So there isn't a zoning requirement, but there's some best practices at least. And then you had a second part, which is the overnight
Yeah.
medical. Yeah, and if
Yes.
Sarah, I don't know if you're on the call right now, I'm not looking at the list. Feel free to pop in if you have more questions. The overnight medical staffing. So I'd say the most important aspect, so you can have any, it really depends on the referring party. Staffing doesn't generally, we haven't really talked about that yet, but like looking at law enforcement doesn't have a lot of, because they're not ambulances, they can drop off to a variety of levels of care. Same thing with street outreach teams, emergency departments. Once they've discharged someone, they can discharge them to a community program. It works fabulously. Ambulances have to go to an equal or high level of care. So if you're taking from an ambulance, that would be like a 911 paramedic ambulance. You'd want to have 24/7 some level of, typically paramedic level higher. So a paramedic, licensed vocational nurse, registered nurse, etc. And the reason this kind of is related to the overnight is if some programs are interested in expanding to say we don't take from ambulances currently, but we're looking at taking during the big surge times. So maybe Thursday through Sunday morning, you'd want to have staff on that could accept from ambulances. The second part of this, I'd say, is the medical staff that you want for overnight medical nursing staffing. Some level of medical staff that can assess a vital sign and make a decision on that. And EMTs could do that with the idea that you want to err on the side of caution. Make sure the staff are aware and that they are empowered to make decisions. 911 is amazing. It exists for a reason. We'd rather have someone go to the hospital via 911 than not and have something negative happen in the sobering center. And I know that sounds kind of logistical, and you're like, oh, okay, that's a protocol. But the staff have to feel empowered. So whatever the staff is, the EMTs have to feel empowered to say, or the peer level, whoever, they're working together on the night shift, they can make a decision that doesn't involve them having to call medical backup all the time. They should be able to say, yes, we can take this individual. No, we can't take this individual. Hopefully you're tracking those. And then solid, easy to use protocols. What are the vital signs? We have so many protocols in existence. Please do not reinvent them. We've got many silver ones out there for people to look at. So can they understand it? Here's what the vital signs are. This is what the client looks like. This is what they fell. They fell, no one witnessed it. They got to go to the hospital. They might have hit their head. Very easy, basic protocols. We don't want protocols maybe 50 pages long, but there's just be some basics where they are empowered to do that. And then ideally some clinical lead or manager, or some communities have used primary care physician groups. Is there like non-emergency? It's not 911. Maybe the nurse wants to call and talk to someone at 2 a.m. about what the person looks like. Some level of backup that the individual could call. And then the last thing I'll say is pure staffing should be there 24/7. But definitely like when folks are waking up in the morning, people have spent the night, like in the morning when they're getting breakfast and they're maybe getting a snack and they're just kind of getting up, and some of them may be getting towards withdrawal and they want to get out the door if that's their medical need. But who can have a conversation with them in the morning? You really want to make sure that there's folks there that can have the relationship with the individual. Also includes the nursing and medical staff, but people who can start calling the detox, calling the shelters and be like, who's got space? So I'll stop there. Keep going.
That's great. Thanks so much, Shannon. So Nancy, I'm gonna unmute you, and so you can ask your question directly of Shannon if that works for you.
Yeah, sure. And thanks for answering that prior question too. That was really helpful. We've been thinking about the impacts of HR1 on Medi-Cal enrollment, and certainly from like a sustainability standpoint, we have a lot of concerns around this, like thinking about if I were to make some general assumptions about the people who are accessing sobering center services, they might not be the ones who are going to be keen on maintaining all this new renewal paperwork and whatnot. Just curious if you have any recommendations or things that we can do, kind of as a community player. We're receiving people as they're intoxicated, right? How much we can't do anything in that moment, right? And then certainly there's like limits on retro enrollment or like, prior payment 1 month prior. So right. Just curious if you have thought through that at all.
Yeah, it's an interesting, and especially so using a subset of the individuals may come to sobering. So I think you're talking about like work requirements and or the constant re-upping
Yes.
of the Medicaid,
Yes.
et cetera, is I'd be
Yep.
curious, does your community offer, like, where do people get their mail sent? Sober Center doesn't need to become the mailbox, but there should, like, where are people getting their mail sent if they're experiencing homelessness? And is there a community partner who can be involved in being like, okay, we're seeing all the Medicaid letters coming through from our community. Who's helping like get that paperwork? Because it's not going to be done unless someone's actually helping with someone. So I'd be curious what people are using for that. It's not really related to sobering, but that would be one of them. It is yeah, but the medical need, that's the thing with the work requirements and such as that. It's just something I think that's beyond the sobering conversation. What would be, are you thinking of the individuals? I'm just trying, before I go down a rabbit hole that makes no sense to what you're actually asking. Is it more of how to coordinate and support the individuals who may not have the wherewithal and capacity, kind of like where's a mail coming to on a regular basis that someone can like work, what's the word I'm going for? Help instigate the conversation. Go ahead, I see you unmuted.
Yeah. Yeah. I think this is just the beginnings of questions that we've been asking. It almost is more like, is there alternative funding that we can use to make us whole? Are there block grants that are being proposed? Maybe, right? Because we,
Yeah.
fully expect
Okay.
that people won't
Yeah.
be able to make this work.
Okay.
But I
Yeah.
hear you
Bigger
too, right?
picture.
Definitely like, yeah, no, but what you were mentioning before, right? Like definitely using the county navigators and like,
Yeah. No.
yeah,
So we're
all
talking
that
more
makes
about like
sense.
the
Yep.
diversity of like funding streams
Funding streams.
and
Yeah. I could have been more
sustainability.
clear in my
Yes.
ask. Sorry.
Okay. No, this is great. There's so much in HR1 that we could dive into. There's a lot of nooks and crannies, to use that phrase twice in the first time in months. I would say that kind of goes back to the idea of like who is currently caring for the clients and what's the best way the potential clients if you don't have a sobering center yet, and what would be the benefit to help alleviate some of that. So alleviating folks out of the emergency department, keeping people out of the jail system, et cetera. Because especially once they've gone to jail and they've been arrested and now they have a record, benefits are lost generally. So getting people out of that situation. So I would say the funding, the investments from the hospital system itself or the healthcare system, Department of Public Health, Department of Healthcare Services, Department of Behavioral Health, between those three different county agencies, I'd say they support probably at least a third to half of the sobering centers in the country, if not more. We'll have better information. We have decent information right now, National Sobering does, and there's a survey for those of you running sobering centers. And we have a survey coming out in the next week or so to talk about what your funding streams are. The criminal justice system, so another bucket is there often funding that's come from the court system to help keep people out of the jail. The sheriff's office definitely supports some programs, in addition to supporting financially, supporting logistically and policy-wise of creating general orders for their officers to go to a sobering center instead of going to jail first. Right of first refusal. Santa Cruz in California is amazing with that, of having officers for intoxication go there first. And as you start getting more people into the sobering center, you can start working with them. More people may be interested in helping fund, but I'd say those entities, the opioid response grants, and there are state block grants. Prior to the current administration, there were conversations on whether or not you could get block grants, say from SAMHSA. That has not moved forward at this moment, but it's because it's a little confusing of where it would fit in. I know agencies, we have a couple of sobering centers that have received SAMHSA funding for substance use in their community that directly supported developing, building out, and hiring the first year of operations for sobering centers. And that has happened. We can talk more. I don't want to give everyone secrets on the line here who's doing what they're doing. And then I'd say definitely investments from hospitals, et cetera, can really help with that. But prior to reimbursement, all sobering centers have been funded by something other than that, other by health insurance for the last 50 years. So it works. Oh, good. Yeah, I saw the shout out to Santa Cruz in the chat. So hopefully that's helpful, Nancy.
Thanks so much, Shannon, and thanks, Nancy, for that question. Pam, I saw your question via chat. I'm going to unmute you so you can ask your question and share a little bit more about the campus that you referenced for Shannon.
Okay, can you hear me?
We can hear you. Go for it,
Hi.
Pam.
Thank you for having this webinar. So I am have been engaged for the last year and a half in repurposing the St. Vincent Medical Center, which is near MacArthur Park in LA. And it is an eight acre campus, 7 buildings, 1 million square feet of space. And this will be a fully integrated campus for people who are homeless with behavioral health, mental health issues, and substance use disorder. And we have locked down the key providers that will be on this campus, but there's going to be a lot of other programs that really contribute to healing, not necessarily the core programs. But in terms of core, we're having a sobering center, intensive case outpatient withdrawal management, a chemical dependency recovery hospital, an adult residential SUD treatment facility. And I put the campus website um, in the chat, so in case you wanted to check it out. And so one of the things that in LA, the key Medi-Cal managed care plans, LA Care and Health Net, have been setting up these care continuums that really are regionally located, that bring all the different providers together. And one of the things the county really wants is this trauma-informed care, which we believe is unrealistic on a campus when you've got multiple programs, you've got multiple people who are at different stages in their recovery, and we don't want to take any kind of risk of drugs and alcohol, et cetera, being used on the campus. And so I'm just throwing this out, for just to see what the thoughts are about this. Obviously, we're in renovation right now. We received 2 B-CHIP grants totaling about 140 million. We've raised 150 million. The health plans have been putting millions into this. And so we are, using ingress, egress, separate, entryways, separate courtyards, trying to keep people separate for the people that are coming in from Justice Involved, people coming in. This is really going to be a hospital campus that will be the other hospital's campus. So they can divert from the emergency room, they can discharge from inpatient.
Okay. So it sounds,
You
I mean,
know,
and I'm looking at the map, it looks pretty incredible. I'm also noticing the purple crisis stabilization unit on there, which I'm
yes.
curious where sobering, is that where you're thinking of putting sobering? We don't have to dive into the weeds of it. You and I should definitely talk offline.
Yeah.
And
So yeah, I'm just trying to understand this whole harm reduction thing. And, I think maybe it might be appropriate in some settings. We're just thinking on this campus, it's going to be challenging to have people come on campus and be using.
okay, so we could definitely dive into this for a long time. And so the trauma-informed care aspect of it, easily feasible. Trauma-informed care is more the seeing people where they're at, providing a safe space, providing a good environment, recognizing cultural differences, gender differences. So that I don't think is the challenge. The harm reduction. So there's a couple ways of looking at this. One, for any crisis stabilization unit, even if you're just doing mental health, you're going to have folks who have intoxication coming into that.
Right.
And so it's teasing out, I think, some of the difference of sobering center where we're trying to stabilize someone to become more functionally sober, like they're intoxicated, they're unable to care for themselves in the moment, they need to sleep it off for a little while. I mean, and that type of thing versus safe consumption site or safe injection facility where people are allowed to do their drugs. And I've visited some of those programs both internationally and domestically, and they're two different things. And I would agree that at the moment, it sounds like that would be a stretch to have like safe consumption where people could go and use the drugs that they brought with them and then go about their day.
Right.
But with sobering center, I don't see a reason why it wouldn't work because we're talking about individuals who are coming in with intoxication. The harm reduction aspects, a couple things that come to mind, and is the idea that who's the population you want to serve? So many people are if you're looking at an abstinence-based only, you're going to eliminate 80% of the people who want to try to change the behavior around it if
Wow,
abstinence is the
80%.
only.
Wow, that's high.
It's a really high. And the thing is if you look at people in recovery, there's and I use the word recovery in the big comprehensive sense. Someone doesn't have to get sober in a traditional way in order to change their behavior and become more stable. And so I think where the focus would be, and it sounds like, I mean, looking at just the photo of what you have and some of the description that you gave, is there are so many services aimed at all the different aspects that could be challenging to an individual to achieving a stable life that is self-directed. So if you've got now, like you've got the permanent supportive housing and you've got the variety of options that are on there, these individuals may stop using the substances that they're on, or they may not. And it doesn't really matter as long as they're doing other things, hopefully to get to a better spot of their lives. So for logistical, would you want someone come into the sobering center, like coming into the campus and having to wander through a whole bunch of things of people who are sober and they're actively intoxicated? No. So ideally, if you can figure out a way to get transport of the individual directly to where the sobering will be, I think it's extremely feasible to make this happen. Ideally, when they're getting discharged, also in a way that they could get discharged without having to be kind of abandoned in the middle of a campus. I'm sure that's
Well, yeah,
not.
no, they won't. They won't. The whole concept,
Yeah.
behind this is to try to eliminate what happens in normal standalone facilities where they go through it and then they discharge back to the street because they're waiting to get somewhere else. They will
Right.
not leave this campus. There's interim housing, there's permanent supportive housing, 800 beds. They're not going to leave this campus until they, they need, to move out to another permanent supportive setting
Oh, yeah.
outside.
Let's talk. This is fascinating. I lived in LA for 10 years prior to coming to the Bay
Okay.
Area. So
Well, we can do
before
this
you email,
offline. I just wanted to say that,
it
we're
can work.
really struggling with this harm reduction approach, but if you're saying that we're going to eliminate, obviously people are coming onto the campus, they're going to come onto the campus
Mhm.
high, in all kinds of, situations because law enforcement is going to be bringing them in off the
Mhm.
streets. Emergency departments are going to be discharging them to the campus. We obviously want to help as many people as we can. It's just trying to
Mhm.
figure out, who can we help?
Yeah.
And, it's okay.
Pam.
Thank you.
Yeah, Pam, I'm sorry to cut you
Yeah.
off, but we're getting close in our time. But
Yep. Oh, yeah. You and I could talk for 2 hours. Let's chat later.
yeah, let's definitely have this conversation offline. I just want to note that we're going to put out an FAQ following both of our office hour sessions. And I think that it would be great, Shannon, if we could tackle
Yeah.
both parts of Pam's question of like, how do you adopt a trauma-informed approach within sobering, and also like, what does harm reduction look like within sobering, both philosophies that occur on a continuum. So we have 3 minutes, and I want to squeeze in one more question because I see that Sri is on the line. So Sri submitted a question in advance. And Sri works at Alameda Health System in California in operations. And they were asking about how best to lead and support sobering centers in their community. So I'm wondering if you can speak to, like, very quickly, what does it look like for a large health system to support sobering centers? And Sri, we can also chat offline too, since we're coming up on the hour.
Yes, and thank you for the question. It is an excellent one. And I wrote a whole page of response, actually. She gave me your question ahead of time. So I will not give you the full page, but I will give you bits and points, parts of it. So for the some logistics directly related to sobering, I would say would be support the hiring of peer professionals within the sobering center. And some of this is going to be when you are making the RFP, and I say you, the county is making an RFP typically, the funding is very limited for individuals who are peer professionals and peer expertise. You're trying to keep, and then often I've seen the response is like, whoever put the lowest bid in is who's going to get the contract. We want individuals to be able to sustain a lifestyle that they can work a full-time job and hopefully not two of their full-time jobs. So sufficient pay and benefits for all staff, not just the licensed healthcare professionals. With that, for within their counties in general, external to sobering, but it may or may not be, advocate to remove the hiring restrictions that are often seen in counties. So the histories of criminal justice history in particular, people who have felonies and whatnot should still be able, like if they are done, they're in a stable life, they're looking for a job, they should be able to get hired into jobs that they want to be hired into. It's supporting people in recovery. I know we've had folks who say we want to make sure we hire individuals into sobering that are in recovery. So we're going to put a restriction in the RFP that says everyone must be able to prove that they've had 2 years of sobriety. That is unnecessary and beyond the scope of what makes a good healthcare worker. Working to engage the potential referring parties, EMS, law enforcement, working with the sheriff, helping connect people. I mean, you guys know everybody. So I think that is one of the areas. And then a couple of the quick ones, because I know we're at the hour, is substance use is often a symptom of another condition. What other resources are available? Talk to the people who are, if you already have a sobering center, what do people need? Housing, respite, et cetera, and help coordinate and work on resources for stabilizing an individual that may, someone's drug use or alcohol use will go down if the other things that are potentially causing it to be harmful go away. They've now got housing. They've got some trauma-informed therapy. Their kids, they have enough money to take care of their kids, that type of thing. I'm in the weeds a little bit. I have more specifics and I'll stop there.
Yeah, no, thanks, Shannon. This was great. We can pull the slides back up while I'm wrapping us up. I just wanted to acknowledge Shannon, because you probably didn't see this. I told Sri we can connect offline and we can add more detail in the FAQ if
Oh,
they
yeah.
prefer that approach too. So let's give Shannon a big virtual round of applause. That was awesome. Thank you so much, Shannon, for being here and for sharing your expertise. A few quick things before folks hop. All of the publications that were mentioned and a few others, the blueprint and the budgeting tool included, are on this slide. You'll also receive those via email and follow up. Um, the FAQ is also forthcoming. An evaluation will pop up on your screen after the office hours end. We really look at your feedback to inform our work in the future, so thank you in advance for taking the time to complete that evaluation. If you have questions specific about sobering centers in California for the California Healthcare Foundation, we wanted to acknowledge that you can reach out to our colleague Melora Simon at CHCF, who is leading the foundation's work in this space. And then if you have more questions about sobering centers, or we didn't get to your question today, it'll come through either in that FAQ or you can join us at our next office hours, which will be Thursday, April 23rd from 3 to 4 p.m. Eastern Time or 12 to 1 Pacific. That's all that I've got. Thank you again. Thanks, Shannon. Thanks, everyone, for being here and to CHCF for supporting this work. And we'll talk to you all soon. Have a good afternoon, everyone.